Well, thank you very much, Rosemary and Maya. And I would also like to thank the organizers of the EPAAC, of the Open Forum, and the Director General for Health and Consumers for the opportunity to be here today and to discuss with you some of the recently published recommendations that are likely to be important in promoting quality in cancer screening in Europe in the coming years. Every time I come back to Ljubljana, I realize I forgot how beautiful it is to be here. And it's not only just the location, but the very good organization of the meeting that really makes it a pleasure to be here and to use this venue. So thank you very much for all the effort. Now, before going into what probably could be some new aspects of recommendations on screening that will be relevant in the future, I think for those of us in the auditorium, or those of you who are not as familiar with the topic, a little bit of introduction would be useful. So I think Adi pointed out a lot of the aspects about the potential impact of screening, but I'd just like to remind us all that not all cancers and the prognosis of not all cancer patients can be improved by early detection. And in fact, you see here in the top row what normally happens in usual care. Is this a pointer? Can I point with that? Okay, so you see here what normally happens. And actually most people would not be able to recognize that they have a cancer until the symptoms appear. So after symptoms appear, there's a delay until the diagnosis actually takes place. And then after the diagnosis, there's also a delay until the start of treatment. But for some cancers, and you see this in the middle, in the B line, the B row, actually it's possible through awareness and through making professionals and also helping patients to recognize the early signs, it's actually possible to move forward the diagnosis a little based on these symptoms. And we know that for some cancers that also improves the outcome and the life expectancy. But for even a smaller number of cancers, it's actually possible to detect the disease before it actually becomes symptomatic. And if we do that, this is what we call screening. You see in the bottom, if we can move the diagnosis long before the actual appearance of the symptoms, then the treatment can also start very soon. And this gives a substantial lead time. And for those cancers, there is a significant improvement in the life expectancy. And in some cases also, in many cases, the serious consequences of the disease can be reduced. So that's actually our goal in screening, here at the bottom. And we know, of course, that screening for breast, cervical, colorectal cancer, which is evidence-based and where studies have shown that the benefit can outweigh the risk. We know that not only has positive effects, it can also have negative effects. Rosemary mentioned this, and also Ati. Because of the huge number of people that are exposed to the screening test, even though the risks of those negative effects are slight, they can add up. And so it's very important to have optimal quality so that the positive effects always outweigh the negative. And that's why, even though for all medical interventions, one always should do the best one can, that's particularly difficult in screening because the benefit can be lost at any step in that very long process that's not only involving the test itself, but also the diagnosis and the treatment that comes afterwards. So it's very important to have an optimal quality in screening. And again, for those less familiar with the topic, even though there are at the current time, only 3 cancers that are where we really have evidence for the population-based screening, it still is a significant proportion of the cancer burden, and in the EU it's therefore worthwhile to try to implement these programs. You see here in the left-hand circle the 3 cancers for which we can screen, and if you add this burden to the burden of colorectal cancer in men, it's about 25% of the overall cancer deaths in the EU. And if we look ahead even over the next 20 or 30 years, if we only look at the impact of the demographic change on cervical cancer, breast cancer, and colorectal cancer, you know, the numbers of deaths will go up. So if nothing else changes, just the demographics. If the lifestyle continues to move in a less favorable way, if our European Code Against Cancer doesn't convince people to adopt more preventive lifestyles, then in fact that burden will probably get worse. Or if we were to stop the screening, which is already ongoing. So even though only a few cancers are currently controllable through screening, the impact is significant, or can be significant, so it is worth the effort. So after those words of introduction, I'd like to come back to the topic, new recommendations on cancer screening, which we can already foresee at this period of time. And if we ask ourselves, where is actually the policy on cancer screening anchored in the EU, I think most of us will agree that it's in the Council recommendation that you see here, or at least the first part of it. And it was adopted about 10 years ago. And core to this recommendation is, of course, the emphasis on an organized population-based approach. We've heard a little bit about that from Ati. And the importance of quality assurance and the European guidelines. So what I think, however, that we need to keep in mind is that many people think of this Council recommendation that all of the health ministers have agreed on, and that actually all of the member states, and the first report on cancer screening has shown that, are trying to implement, even though it takes quite a long time, and you'll hear much more about that in the other presentations today. Even though people talk about a Council recommendation, in fact, it's not just a recommendation to conduct screening. In fact, this Council recommendation is actually a package of recommendations, about 30 altogether, and they actually advise the member states on key things to take into account when they decide to set up a screening program, and in fact, even advice on how to decide to set up a screening program. And once one is being set up, what needs to be done to monitor it and evaluate it, and even consider perhaps to stop it. So it's a whole actually package of policy recommendations. And the principles are based on the principles that have been established long ago by the WHO, but also on the additional knowledge that's been gained in Europe in implementing screening programs over the past few decades. So what we actually have is not just a recommendation to screen, but a recommendation on what to consider in making that decision. And again, quality is absolutely essential. And if there is one other area where we can look to find the European policy on cancer screening, it is, of course, in the guidelines which are recommended by the Council. And if we're looking to new recommendations, of course, we would want to look at the recent publications related to these guidelines. The most recent guideline being the colorectal one here on the right, published in 2010. And there were some recent publications dealing with this last year. And I'm very happy that I can announce to you today that also supplements to the breast screening guidelines have now been uploaded onto the Commission website, and you could now download these these new supplements, and I'll talk a little bit more about that. So, what we know from the Council recommendation is, of course, not only the things to keep in mind when a country is thinking about recommending screening, but there is also that annex, which you see down here, showing the 3 evidence-based tests that were recommended 10 years ago. And in fact, the anniversary will be next week. It will be exactly 10 years since this was adopted. And I think after 10 years' time, we would all agree this would be a good time to go back now and revisit this list of recommended tests and to see, do we have more advice in the guidelines about how to do screening? Do we have more evidence perhaps from somewhere else? And to see, in fact, if this list should be updated. But I also think most of us would agree that the principles which should be taken into account in making recommendations to screen probably haven't changed in the last 10 years. And actually, they've survived the test of time, and so probably we wouldn't want to change them. But so coming back, so what do we know now? What are the recent publications that have come out that could be relevant? And I think some of you are aware that last year the colorectal guidelines were published in a journal format to make them more accessible to the scientific community and to disseminate them more effectively. And to announce this supplement, an overview was prepared of the guidelines, and it was prepared by all of the contributors, over 100 contributors. And actually, the only really new thing that was mentioned was that when the colorectal guidelines were prepared in 2010, there was already a lot of evidence about the efficacy of colorectal screening with the flexible sigmoidoscopy. But the evidence wasn't so strong that one would definitely recommend it. In the meantime, there have been 2 publications of randomized controlled trials, one organized, coordinated in the UK by Wendy Atkin, one coordinated in Turin by Nero Senyan, who is here today. And these very large randomized controlled trials actually have provided a lot of convincing evidence. So it's pointed out in this overview that actually there is very strong evidence, not just for the fecal occult blood test and FIT, but actually also for flexible sigmoidoscopy. And so I think if we're talking about new screening recommendations, this is something to consider in preparing an update of the annex to the Council recommendation. The other new publication, which I just mentioned, which is now available and can be downloaded from the EU website, is the supplements, the initial supplements to the breast screening guidelines. These supplements were prepared to sort of bridge the gap between now and publication of the 5th edition or the next edition, full edition of the breast guidelines. And the first 2 supplements, which are now available, deal with digital mammography and also an update of on pathology. And I think particularly relevant for the discussion after the coffee break, which will have a lot to do with problems and challenges, but also solutions in implementing population-based screening in Europe, is the annex, which deals with successful implementation of population-based cancer screening programs. It applies actually not just to breast cancer, but also the other cancers as well. And to just give you a brief overview, the supplement on digital mammography, it doesn't repeat the entire physico-technical protocol. It only includes the things which have been changed because digital mammography has continued to advance since 2006. So you will find the same numbering in this supplement. It corresponds exactly to the numbering in the original guideline, so that the physicists can more or less put the 2 next to each other and see what has changed. But what is completely new is the second part, which is the European type testing protocol. And the idea behind the European type testing protocol was that actually the manufacturers across Europe have completely embraced these guidelines. And in fact, around the world, people were just waiting for us to update the digital mammography guidelines. because of the recognition that they are of a very high quality. And many manufacturers would have preferred, when they are actually building the equipment and designing the equipment, to already design it in a way and put it together in a way that the equipment could if it is used correctly and if it is calibrated correctly, would definitely be able to pass the European guidelines. It's a sort of a waste of time and effort if after the machine is designed and built, the manufacturer realizes, oh, actually we built something in the wrong way. So the idea behind the European type testing was to actually improve things right from the start. And this is now available for digital machines, and the same model will be used for other equipment which is used around imaging in the future, not just actually producing the mammogram. So that is a major step forward. And in the pathology guidelines, I don't think there are too many pathologists in the room, but I always find that a little bit specialized. But in fact, the pathology working group had a number of meetings over the past few years and felt that these topics had to be urgently updated before the next full edition of the guidelines. So they are now available. And the annex, which I think is very relevant now for those of us who are trying to improve programs or even trying to set new programs up, includes the results of a meeting about 2 years ago in Stockholm, organized by, co-financed by the EU and organized by the USAN project to help other countries in the EU develop scientific advice for their healthcare systems. And at this meeting, a number of experts in implementation of cancer screening met and reviewed the evidence and tried to come up with some good advice on what are the key factors to take into account when implementing programs to actually be sure that they follow the European guidelines. The more extensive report of those discussions has been published in the European Journal of Cancer by Elspeth Linge and the group here, and also a briefer statement intended more for the policymakers to really sort of summarize in a very short space the key issues, has also been published now in the guidelines as a statement. And I think that statement is quite important because for many of us, it's rather easy to get the government to pay for a service, to pay for another mammogram, sometimes even to pay for another mammography machine. But it's rather difficult to get them to pay for something intangible, which is quality or coordination, even evaluation. It's sometimes very difficult to get the government to understand, without setting up the screening registry in a very good way, actually the quality cannot be assured. So we were careful to include in the Stockholm statement an estimate of actually how many resources should be provided for quality assurance. And we pointed out that under routine conditions, most programs would need 10 or 20% of total expenditure just for the quality assurance. And for those of you starting programs up, where the volume is low, in fact, the proportion needed for quality assurance is much, much higher. And if one doesn't have a number and one doesn't have a statement or a recommendation one can point to when negotiating with the government, it can be rather difficult to actually get the funds that are needed. So I think this is starting to close the gap. So now we're coming close to the end. Thanks a lot. So I tried to summarize more or less in the last 1 or 2 slides some of the key messages in this annex. Of course, the most important thing is the role of coordination. That's what you need from the beginning. It should be an autonomous team that is responsible but controls its resources. Screening is a long-term endeavor. It requires societal commitment, political support. You need all of the registration, all of the IT. And one needs very effective governance so that one gets not just the support one needs, but also the supervision. So those, I think, are some of the key messages that we should be taking into account in the coming years. Thank you very much.